Could the next disruptive revolution be mechanical minds, support for young leaders from across the globe, and looking ahead to Anesthesiology 2016, right now on ASA TV. Hi, I'm Ed Highland, and this is ASA TV. All week here at Anesthesiology 2015, we've heard from a series of groundbreaking presentations, and today attendees were challenged to consider what the future might hold in the John W. Severinghaus lecture. The namesake was on hand for the remarks. Modern critical care can be directly traced to Severinghaus and his development of the blood gas machine. This year's address, delivered by Dr. Stephen Schaefer, centered on artificial intelligence and how it could shape treatment options in the future. Dr. Schaefer chronicled the history of computer cognition and the fears about it, but says computers can never replace us.
We built the world with our hands. Civilization evolved because we are dexterous. And there's nothing like human dexterity anywhere in development.
Schaefer does believe there is a place for computer cognition in patient treatment. Memorial Sloan Kettering Cancer Center is developing a treatment tool with IBM's Watson. By having Watson learn decades of data combined with its analytical speed, it could create ideal personalized treatment options. Schaefer believes one day it could be as commonplace as getting driving directions on your phone, with Watson helping to direct the stages of patient care.
I'm ready now. Bring it on. I had no idea how advanced Watson is in being able to make decisions and to help us make decisions. But I'm also reassured that he said that we're not going to get replaced. So very important to me, of course, to be able to use my hands and do anesthesia, but have the decision support of Watson to help me out.
I think there's maybe not reason to fear, but we always have to remember about garbage in, garbage out. So how much of what goes into these systems is fact and how much is we don't really know. So how does that factor into decision making? But certainly there are great opportunities in the future for adding help to decision making.
Complex regional pain syndrome can be frustrating for patient and physician. This session, led by Dr. Richard Rauch, details how fractures are the most common trigger, and women are affected 3 times as often as men. Despite the fact no drugs have been approved in the U.S. for treatment, physician researchers are making slow but steady progress.
Take home is that we're making progress that way. I think there's still a lot more work to be done, and that these patients, there is a lot of hope for them so that they can get treatments both pharmacologically with medications. There are often interventions that we can do along with the physiotherapy to really make them better.
We also face more challenges with payers, people saying that there's not evidence to support what we're doing, and they're right, there's not enough evidence, but there's not a better alternative either, so we're hoping for things to come out, but keeping updated on this really helps.
One of the most important things to do as a clinician, both in private practice and in academic practice, is to be able to benchmark yourselves to the best people in the world. I think this is probably the best overall summary.
A session on neuraxial labor analgesia and pregnancy outcome explored whether epidural analgesia affects the cesarean rate and if the type of epidural and timing of it play factors.
We showed that epidurals do not cause C-sections. They are probably associated with an increased risk of instrumental vaginal delivery, although that can probably be influenced by the type of analgesia that we do. Epidurals do not prolong the first stage of labor. They prolong the second stage of labor. The question is whether that has an adverse effect on the mother when the second stage of labor is longer. And that question we haven't answered yet.
From routine cases to mass casualties, anesthesiologists must be prepared for anything. Anesthesiologists are trained to manage a broad spectrum of patients, from pediatrics to geriatrics, from the healthy patient to the medically complex. While mass casualty events are rare, it's important to remember to take care of yourself during one. You must rest, hydrate, get proper nutrition, and psychological support. For patients, keep them warm in the OR and focus on damage control resuscitation. For up-and-coming anesthesiologists, the hands-on workshops provided a unique opportunity to literally stay in touch with the best techniques the specialty has to offer.
This course is excellent, and it helps me with the target practice, with the needle and ultrasound guidance. It's also helping me learn the anatomy, and it's a good way to get through all the blocks quickly, and then you could go home and read about them and improve on your skills.
It's really important. I'm a first-year resident, so this is quite all new to me, but the sessions are really good, the models as well, and they explain it with very specific details, so it's very good. I'm enjoying it.
New this year, 3 young leaders from low and middle income countries are participating in Anesthesiology 2015 thanks to assistance from Global Humanitarian Outreach in collaboration with the ASA Charitable Foundation. The Global Scholars Program gives these anesthesiologists a global network of colleagues, important connections for these individuals often isolated as one of just a few anesthesiologists in their home countries, and they gain invaluable knowledge to take back to their home institutions.
The other thing is that much of our anesthesia is provided by clinical officers. They are like technicians who we are not so sure how well trained they are. So again, the quality is much of a problem.
In my hospital, I'm the only anesthesiologist, and although the other people are technicians, so they work a little bit different from how we do. So if we try to change things in them, I think we're gonna be better.
We have a lot of patients and not enough lack of the employees, anesthesiologists, and also lack of the equipment.
I think the ASA meeting is substantially richer because people like our global scholars are here to interact with members attending the meeting and to open their eyes.
The ASA's Charitable Foundation and its Lifebox initiative were also presented with a $5,000 check from Teleflex. Funds raised through a game held during the annual meeting at their booth. And in the closing hours of Anesthesiology 2015, we are looking ahead to Anesthesiology 2016. I'm joined now by Dr. Daniel Cole, who is the president of ASA. Dr. Cole, thank you so much for joining us. We're looking ahead and thinking about what kind of priorities do you see for ASA in 2016?
Well, next year is a vital year for our specialty, and the top priorities would be protecting the quality and safety of our patients through maintaining and ensuring physician-led care of anesthetic care throughout a patient's experience. The second one would be some of the payment models that are coming out and all the changes that will result in healthcare system remodeling and making sure that our members have the ability to have a business model which maintains high quality and safety.
Will you be focusing on specific areas of the specialty in 2016?
Oh yes, certainly there'll be a few areas that will be very big highlights. One, we'll have a patient safety initiative to assess post-operative delirium in patients with kind of an emphasis on maintaining your brain health. Secondly would be the advancement of research and the discovery of new knowledge to make sure that we answer some of the big questions that are still unanswered within anesthesiology.
Dr. Cole, here's to a successful year.
Thank you so much.
And thank you for watching ASA TV. You can look back at any of the videos for this week, including the one-on-one interviews, right on the ASA YouTube page and inside the ASA My Meeting app. For ASA TV, I'm Ed Highland. We'll see you next year in Chicago.